Let me thank the organizing committee for having invited me in this outstanding meeting. I will talk in the next few minutes. I will talk about percutaneous ablation for current liver meds and mainly focusing on technique and outcome. First of all, as you know, the heat therapy is not new in the cancer therapy. There are some papers published and available since 3000 before Christ from Egyptians and ancient Greeks. The rationale behind the thermoablation is the absolute sensitivity to the heat of every biological tissue in this earth. And every cell will die at a temperature higher than 50 Celsius degree thanks to the coagulative necrosis. This is the range we have just to work with the ablation that start from 50 Celsius degree until more than 110 Celsius degree, which may achieve tissue localization. So in terms of biological point of view, there's no difference if we take out the tumor or if we ablate it in the liver. Up to now, we have at least two most common techniques for percutaneous ablation. One is the reference ablation, that is based on the current flowing through the body, but however it's been almost completely replaced by microwave ablation, that is field-based technology based on the switching electromagnetic fields that generate frictional heat from oscillating dipoles. And it will lead for increasing the heat at the level of the tumor thanks to the active heating zone, and due to the very high temperature reaching by the microwave technology, we may even think about achieve a passive heating zone due to the spread of the heat through the tissue. Why thermoablation? First of all, because a minimal invasive approach, and it may reduce complications and side effects. It may be indicated in such skilled situation where surgery is not amenable. However, one of the unique feature is the repeatability, and this is mainly important for metastatic disease and carcinoma. Some other features are shorter recovery time if compared with surgery. No need for long break from chemo. It is mainly true for metastatic liver disease. It is cheaper than surgery, and for instance, according to the very recent experience with pandemic, it is even a shorter hospital stay. It's a great opportunity, has been a great opportunity during the pandemic. This is an example of very well done thermoablation for single colorectal liver mets. Here the huge ablated area 24 hours later, 3 years later, 8 years later. One of the most important or not one, but at least two very important elements have to be considered when we do ablation. The first one is the dimension of our tumors. As you can see here in this paper that has been published by Sophocles from Memorial Sloan Kettering, demonstrate the big differences between the lesions below 3 centimeters and the lesion higher than 3 centimeters in terms of local tumor progression-free survival. Another important issue is the ablated safety zone. So it means how big is the ablated area of normal tissue around the tumor. As you can see, the big differences between a safety free margins larger than 1 centimeter if compared with those patients who didn't have any safety margins. So the big difference even in local tumor progression-free survival. So important to consider all the lesions up to 3 centimeters and achieve an ablation zone that has been between 1 centimeter and 5 millimeters. So regarding the guidelines, the ESMO clinical practice guidelines introduced the toolbox for treating oligometastatic disease in patients with colorectal cancer. Of course, surgical resection, RC resection is what surgeons have to achieve in resections. And in all the local treatment, the aim is just to achieve the same result of surgery R0. However, the non-surgical local approaches are considered mainly in those patients who are not available for resections for many reasons, and this is mainly because data supporting the guidelines are only retrospective. For instance, this is one of the papers where the patient has been treated with frequency ablation. This paper has been used for the guidelines. As you can see, the authors only considered the patient unresectable. So they include only patient treated with frequency ablation were not amenable for being resected. According to this experience, with a big difference in terms of overall survival, if you consider patient with frequency only and resection plus frequency, the authors stated that the proposal for a randomized trial comparing the frequency ablation versus resectable liver mets may be inappropriate. However, in 2017, has been published the data coming from the COC trial comparing patients treated with combined modality harm, so it means local treatment and chemo, with the arm with only chemo. And both the 5 years and the 8 years survival rate was completely different, much higher in those patients who received also thermoablation together with chemo. And this is the big differences in the two curves in the survival probability. So those results were good enough for advocate a randomized clinical trial comparing the thermoablation with the surgical approach in resectable patients. Also, the data of adverse event were in favor of thermoablation. If you consider those papers has been included in this systematic review and meta-analysis, the 30 days mortality was much higher in the arm of resection rather than thermoablation, even if the overall survival seems to be much higher in the group of paper based on the group of patients treated with resection. But however, don't forget that the big bias of those patients who were included in those studies were mainly unresectable. So the others concluded that there were enough data for stress a randomized control trial together comparing both the two groups. This is the reason why many randomized clinical trials are ongoing. This is one of the most important ones. That's been proposed by the Netherlands group, and it is a phase 3 single-blind prospective randomized clinical trial started in 2017, where the objective is to prove the non-inferiority of thermoablation if compared with hepatic resection. These are the included criteria. The expert panel divided the patient and selected the patient amenable to be randomized, and the two arms then were resected or ablated, and with a very long follow-up, at least 5 years. The interim results included 94 resections and around 100 ablations. And regarding complications, again, ablations were more really safer and more conservative rather than surgery, who had 2 deaths due to the resection. But if we take a look to the results in terms of effectiveness of the ablation, you can see the local tumor progression-free survival of the patient treated with ablation is perfectly overlapping in with the patient treated with the resections. And this is even true if we consider the overall survival. Pardon me. However, in the group of patients treated with the ablation, they noticed a big differences in tumor treated with the navigation system. So it means with confirmation software and fusion imaging, if compared with those patients treated with conventional ablation, that means imaging guidance only, ultrasound or CT. So the frame engines and the navigation system are really mandatory for achieving a very good good results. What about the ultrasound and CT fusion imaging? This is a brand new technology that's been introduced around 10 years ago. It may allow just to overlap the real-time multiplanar ultrasound guidance and images with the dataset coming with CT that brings the spatial resolutions of the CT and the enhanced imaging. So by overlapping the two images, we may take advantage of the real-time and the imaging and the very high spatial resolution of CT imaging. So it will increase the detectability of small lesions compared to the mode only, facilitates accurate placement into the tumor, reducing attempts of needle position, and it may even reducing the ablation session in those patients with more than one lesion to be treated. In our facilities, we even include one lung ventilation in order just to keep the right lung completely still, not just to maintain the liver completely still. It will allow to have even a much better overlapping of the images. This is an example of a patient who was previously resected and he had a relapse at this level where it was resected and new lesions in 7-7. So this is the our facilities. So the patient has been in general anesthesia with lung ventilation studied with the CT scan with contrast medium. You can see both the two lesions, our target, the relapsed and the new lesions, big one. This is the stage of the navigation system. So data set was sent to the ultrasound in order to allow the overlapping of the two images. Because the small lesion in the 7-8 was not visible on ultrasound, we just placed the digital landmark on the CT, and you can see the digital mark because the two images are completely well overlapped, can be seen here. So we needed just to stick the needle where the landmark is located, and it will be really precise because the two virtual image and real image are perfectly overlapping because the patient is not breathing in the same position. So this is the steam come out during the ablation. Of course, both the two lesions, the small one and the other big one on the 7-7 has been treated, and this is the result. Huge ablations. 2 years later, patient still disease-free. Of course, the navigation is important, but even free margins is our goal. So this is another case, a small lesion, very close to big vessels. The CT immediately after show a very huge ablated area. So we wanted just to be sure that even here we reached the free margin, the 5mm free margins. Unfortunately, it was not the case because our confirmation software told us that here in this posterior and medial aspect of the tumor there will be still some viable tumor, or however no free margins. This probably because of the two vessels. So it was very easy just to put the two landmark where the risk of viable tumor is still in place. We can see here the two landmarks are here in the ultrasound image. So we need just to stick the needle where the two landmarks were placed and do the ablation. And this is the afterwards the outcome. So it was before, and the confirmation software told us that this is class 5. So it means at least 5mm margins around the tumor. I would like just to let you know that the conditional probability with regard to primary endpoint was are almost reached because the chance that ablation will be superior or equal is around 88%, very high. So, according to the interim data from collision, we know the translation of lesion between 0 to 3 centimeters is superior regarding mortality and adverse event, with significantly reducing hospital stay. It is at least non-inferior in local tumor progression-free survival and local control, and probably it will be even non-inferior in overall survival. This is the chance, at least of the interim data, of these data. Let me introduce the CMR. That is a prospective observational non-interventional study. It is a European registry that is driven by the European Society of Interventional Cardiology, with the primary endpoint that is local tumor control at 1 year after treatment on a lesion basis. In January 2023, this year, we stopped the enrollment. We reached 500 patients. It means 803 tumors. These are all the hospital included. The interim analysis now are studying 452 patients for an amount of around 700 tumors. They are just interim data regarding the safety. And as you can see here, we only collect up to grade 4 adverse event. Majority of them are related to the pain, and no death are up to now registered. This is the outlook of the study. We are here today. We are just doing the follow-up of our patients. So, dear colleagues and friends, in conclusion, we may state that terminal ablation for chronic ailments is now achieving increased evidence of efficacy in prolonging overall survival. So, very soon it will be included in the guideline as well as the surgical approach. The ongoing randomized clinical trial comparing terminal ablation with the standard that is surgery are really promising in terms of results. Terminal ablation may be improved thanks to the techniques that may allow a better outcomes. It is mainly come with the fusion imaging technique that may allow us just to be really precise and safe in sticking the needle into the tumor, and even confirmation software that may be allow us just to be sure about the safety margins. Of course, we need a qualified standard practice in order just to reducing the huge variability in patient selections, but even treatment techniques that still ongoing in many centers. Last but not least, don't forget the multiscleral tumor board that if is well balanced may be very helpful for a better patient selections. Thank you for your attention.